Good afternoon, ladies and gentlemen. I think we'll get started if we can. There'll probably be a few stragglers because parking's always a challenge. I'm Jenny Mobbs and I'm the CEO of COTA ACT. Welcome this afternoon. And can I pay my respect to the traditional owners of the land on which we meet today, the Ngunnawal people, and recognise that they have contributed and still contribute to our practices in the ACT. Today, we're very fortunate to have a couple of people here from the University of Canberra, Nathan and Georgina, who will be talking to you soon, and also Nicole from Dementia Support Australia, ACT. Thank you all for being here today. It's great. This is one of our bigger sessions, as you can see, and I can see people that I haven't seen for a few months, so a special welcome to all of you. Just a little bit of housekeeping. If you want the bathrooms, they're out into the foyer and turn left. And if you want the COTA office afterwards, out and further to the left down the end of the corridor. And if you could hold all of your questions until the end of the session today, that would be appreciated. We do have a very yummy afternoon tea, so please stick around and you can talk to all of our speakers after the session today. The session today is all about dementia. Next month, you know, we have these sessions every month. Next month will be on cardiovascular health with a Heart Foundation and Empower Better Health. So always an interesting topic we have here. But if you can think of something that you would be interested in and you think your friends may be interested in too, please catch up with Catherine and let her know, or email us and suggest a topic, and we will follow that through later in the year. I think we're planned up to about June now, aren't we? September. Well, you'll get something in October and November. There you go. But please let us know, because these sessions are really for you, not for us. We organise them, but they're certainly information packed and they are for you. So welcome to all of you today. And I'm going to now hand over to Georgina, who's from the Centre for Ageing Research and Translation at the University of Canberra. Thanks, Georgina. Page.
Good afternoon, and it's great to be here. Yeah, I'll make sure I hold this nice and close. You can hear me okay down the back? Yep. All right. Great to be here. And yes, my name's Georgina. I'm from the University of Canberra. Thank you for the welcome. And I hope the welcome is continued once I tell you that I'm actually a Victorian, living in Queensland, but working in the ACT. So, yeah, a few different sort of places I've lived and worked, but yeah, Victorian born and bred, but really enjoying my time here in the ACT so far, and the beautiful spaces that you have to live and work and retire. And yeah, so just want to introduce today, we'll be talking about a number of different things. So Nathan will follow up after me. I'm going to talk a little bit about brain health, dementia, and some healthy choices and preventative type things, and sort of what the research is telling us about maintaining our health over the years, our brain health. And then Nathan will follow on from me. So again, thank you for the acknowledgement of country, and I'd also like to acknowledge the Ngunnawal people as the traditional owners of the lands on which we work and learn and join together. So I'd like to pay my respects to elders past, present, and emerging, and any Aboriginal and Torres Strait Islander people here today. So a little introduction of our team at the university. We recently became a centre at the university, and basically we're a bunch of researchers that have an interest and passion for seeing, I guess, policy and practice and evidence around staying healthy as we age and supporting people as they age with the best healthcare and community services that we can offer. So our research team is made up of a bunch of people. In the photo there, you can see at the centre our lead, distinguished Professor Diane Gibson. You can tell that's Nathan on the left. We've got Ash, Kasha, Anadin and Stephen. And so I just recently joined the group in January, and excited to be a part of this team that's making a difference. So let's get into the topic, and just I wanted to share today. Why talk about dementia? It's not always a positive topic, is it? We see it in the media, and it can be really portrayed as scary and fear-based information about what will happen to us as we age. But I think, and I know because we're here today, that it's important to talk about dementia, because understanding is useful and it brings us information that perhaps we didn't already know, and it gives us information about the future and what we can do to either help ourselves or to support others. So talking about dementia also connects us to where we might find support when we need it, and things that are in the community. And also it provides that support to people who are living with dementia and their caregivers, so that as a community, we're reducing that stigma around a condition that people are living with and supporting them. And I think that's really important. So each one of you will leave here today with a little bit more information and understanding about the condition and how we can support each other. So what is dementia? Sometimes words are used interchangeably to describe dementia and the conditions associated with it. Dementia is actually a collective term. It's not a disease itself. It's called a syndrome. So it's like a collection of symptoms that have similarities. So there are a number of underlying causes of dementia, and they can be anything from a disease. Potentially, the research is still establishing the direct links here, but head injury or abuse of substances like alcohol. So there's a number of different reasons and underlying causes. So you might be familiar with some of those other terms there, which are the underlying diseases that result in, that cause these symptoms of dementia. And these include effects to the brain function. So you might be familiar with some of these. So people living with dementia have impacts to the way they think, the way that their memory works, and there's all kinds of different memories. So don't assume that if you're forgetful about one particular thing, that it means your memory is gone. And memory is such a complex and intricate thing. And if I meet you again in the supermarket tomorrow, I might not remember your name, but I know that we met. That's a memory. And those memories can be emotional, and the way that we feel when we see each other. So that's an interesting one. Dementia also affects brain function, attention, and ability to do everyday tasks. It can interfere with social connections and work life. It also can impact the way people speak. So that can be putting sentences together. It might be the speed at which someone talks. So there's a number of different things. When you hear that word dementia, it has a group of symptoms that are commonly associated with it. At the moment, there is currently no cure, but there are some treatments that can offer positive effects, and I won't go into that too much now. But just to sort of, as I said, explain what dementia is. I think the other really important thing is dementia is diverse. And you may have heard someone say, if you've met one person living with dementia, you've met one person living with dementia. Right? So the medical cause and the prognosis of what's underlying the dementia is different for different people. the context of how they live, their treatment, and their experiences are different. And the other important thing is, you know, we are all unique. We don't experience things the same way. And we are also incredible. Do you think? Some of us, yes. Okay, I want you to have a think about this phrase that I'm putting up on the screen now. And maybe you can substitute that word dementia with another condition like cancer or diabetes. And then I want you to have a think about this phrase. So when we meet and know people living with a condition, it doesn't define their whole selves. And I think that's really important. That person is a person and they're an incredible person. Okay. You can tell I'm passionate about this. I have a loved one living with dementia, and that's been a journey now of over 13 years. And so as a family, you know, these are some of the things that we've discovered because initially we didn't know a lot. And so, yeah, I'm really passionate about sharing the message that people living with a condition, you know, are incredible. So dementia causes, I spoke a little bit about this in a different disease underlying. And if I put up this list, it looks a bit overwhelming and scientific. But currently research is sort of establishing and teasing out some of these things that may contribute or that we know now are linked with the causes of dementia. So there's a number of different physiological changes that are associated. So, you know, you might have heard of like some people are genetically predisposed to dementia. That's quite a sort of a more minor cause of dementia. It's not that common. But you may also have heard of tangles and plaques that have been found in the brains of people that have lived with dementia. But science is still really teasing out just how these work. And, you know, things like trauma and chronic stress over a lifetime, that's really hard to sort of tease out and understand. Let's have a think now. The other sort of flip side of this is we can't necessarily know about the science and all of those intricate physiological reasons, but there are things we know already that are associated with lowering the risk of dementia. Increasing the risk of dementia. So Western dietary patterns, like a high fat, kind of high carbohydrate, low in fibre, and those kinds of things as a dietary pattern. Being inactive, smoking, depression, high blood pressure, and even isolation from social connection. And that's a really important one there. There's also research around sleep patterns, hearing loss, and how that might affect the risk of dementia. So that all sounds a little bit heavy and a bit maybe overwhelming. As I said, there's research ongoing to understand the causes and potential cures. But there's also research about how we can live well with dementia, and that's, I guess, what Nathan and I and our team are looking to do. So I want to now share some positive things that can, as we said, reduce the risk of dementia and keep our brains healthy as we age. So you might have heard this saying, what's healthy for your heart is healthy for your brain. Has anyone heard that before? No, I've heard some maybe. So a lot of the messages over our lifetime, we've probably heard from the Heart Foundation about eating well, exercising, you know, avoiding certain things like alcohol and smoking. Well, a lot of those things are actually really important for our brain health as well. So you can sort of take on that overall message of, thinking about the different parts of your life. That include things like being physically active, and that can come in different forms. So strength training, balance training, just getting out and moving. So I definitely count gardening as being active. A variety of nutritious food. So a lot of us probably know what is a healthy diet. Nathan is the expert on this as a nutritionist and a dietitian. But yeah, I guess focusing on vegetables, fruit, whole grains, quality proteins, drinking water, and limiting alcohol and soft drinks. A really important one is this social connection, and I'll talk about that a little bit more. But the other thing is, how is our sleep? Are we getting quality sleep? And do we have something that is meaningful for us to do during the day or the week? I want to just share a couple of ideas here that I've put together. And I've put together this like a bit of a pizza or a pie. Now, if I asked you to go away and change something about each of those pieces, it's pretty unlikely you're going to be able to do that. So I'm going to suggest you pick one and just make a little change in one area of that pizza. Now, I'm a bit biased because my background is in exercise and physical activity, so I'm going to suggest a physical activity one. And I want to give you a couple of ideas around that, and just to encourage you about some positive things that might be a little bit outside the box to what you've heard before. How am I going for time? I won't be too much longer, but yeah, just wanted to highlight a few things that may be different or new to you. So I did not want to put up a picture about being physically active that had a happy couple walking on the beach. And I didn't want to put up a picture of a young lady or man at the gym in their, what do we call it, active wear. So physical activity, anyone who likes to do it, we know that it's not necessarily sexy, and it doesn't always feel good, does it? Sometimes it's a little bit uncomfortable because it pushes out of our comfort zone. But at the end of it, we usually feel pretty good. I want to share just some ideas. Has anyone heard of blue therapy? It's a little bit, I guess, like green therapy, so getting outdoors in nature. But in this particular regard, near the water. So for people on the coast, that's being near the ocean. But you guys have such a beautiful lake here. So being near water and other blue sort of spaces is actually shown to be healthy for you and to bring positive feelings, like when you're active. And if you're combining them together, you're getting an extra boost. I'm just going to jump forward because I have a slide. If you want to Google blue therapy, you'll probably come up with something like that. Surprising benefits of blue spaces and blue therapy, and that gentleman talked about his mental health and how being out sailing helped him. Okay, this other one that I came across a few years ago and sort of read up a bit about the research. It's a Japanese term called Shinrin-yoku, and translated it actually means forest bathing, which I think is quite elegant. So spending time in green spaces, in nature, and if you're combining that with a gentle walk, taking your grandkids out or something like that, you're sort of combining those positive things. You can move and experience those positive spaces. Any park runners here? Oh, someone's got their hand up. 2. Awesome. How many know about parking? Yeah, lots of you. So that's a really positive thing too. It's such an inclusive space, and I love the fact that part of their messaging is nobody finishes last, because they always have than a walking at the end. So for those who aren't familiar, go home and Google parkrun. It's basically every Saturday morning globally. There's a whole bunch, like thousands of sites where people come together and do a 5K walk or run. And you can volunteer too, so that's another positive thing. Chair yoga. Anyone doing that? Yes. Yeah. So again, I want to sort of encourage you to think outside the square a little bit if you think about being active, moving for the benefit of brain health, but also your whole health. It doesn't have to be that idea of jogging or being at the gym doing weights. There's lots of different options. So the other one I wanted to mention, and some of you here might be part of the choir, but the Alchemy choir that meets here each week on a Thursday. And you know, the power of coming together and sharing music. And the thing I like about music is what happens when you listen to music. You feel like moving, that's right. But you're also getting that, you know, social connection. It's not just you out doing a lonely walk, you're connecting with others. So I might wrap up there, but yeah, just wanted to leave you with some positive sort of different things you can do for your health, and just think about that combination of like being socially connected and moving. And that can make a significant difference to how you feel and how you look after yourself, I think. So, I don't know.
Thanks very much, Georgina, and thank you for having me here today. My name is Nathan, and I came to dementia research and being interested in dementia in quite a similar way to Georgina, through family experience. And, you know, I guess thinking about this first slide here and what happens when someone is diagnosed with dementia, there's a personal connection to that for me with my parents, and receiving conflicting messaging from different health professionals after one other started to experience symptoms of dementia. And for many people, you know, receiving a dementia diagnosis can be, you know, quite an experience or an ordeal. It's not like that for everybody. Certainly there are not great, but experiences out there where people do receive a timely diagnosis, but for many, it can be an ongoing process. And receiving that diagnosis can be quite confronting as well. And certainly people can be bombarded with different information, different services that they should potentially access, and it can be very overwhelming. And so a lot of our work at UC and the Centre for Aging Research and Translation is around that experience after a diagnosis. How can we influence policy and practice so that people can be equipped with a toolkit to be able to remain engaged in activities that are meaningful to them moving forward, and be able to access support when they need it, rather than potentially needing it at a time of crisis. And I like this figure here, because what we really want to do is to be able to have people with dementia and their care partners, who are so important. They provide an essential function to our economy, looking after a person with dementia or supporting them after that diagnosis, is to receive early intervention so that, you know, they can get on the path to, you know, remain living at home for as long as possible, and also being able to do things that are important to them, like a lot of what Georgina has spoken about, remaining socially connected, physically active, and being able to spend time with their loved ones, and doing things that they, you know, make them feel alive and feel moved, as Georgina said. So when you think of this term rehabilitation, you might think, oh, you know, I've pulled my hamstring, I've got to go to the physio and get some treatment. But in reality, it can be a lot more than that, and it can be different for specific health conditions. So dementia is an acquired disability, meaning we're not born with dementia, with the exception of some rare types of childhood dementia. It is something that we acquire over our lifespan. And as Georgina said, each person will experience symptoms of dementia in their own way. Now, if someone receives a cancer diagnosis or perhaps they're diagnosed with type 2 diabetes, there's relatively good pathways to receiving support after that and treatment pathways, but that's not always the case for people who are diagnosed with dementia. And we strongly believe that people with dementia deserve that right to receive that access to rehabilitation and allied health services as well. And it's definitely something that has been identified as lacking across Australia. We do a lot of things well here, but I don't think we do this particularly well. And a lot of our work is focused around that. So what does it mean in the context of dementia? It means maintaining activities, independence, and quality of life. And we know that there is evidence suggesting that some interventions may slow the progression of dementia. So like you saw that figure before, we want to delay cognitive and functional decline into the future. And we also know that, as Georgina said, everyone's experience of dementia is different. So treatments and approaches should be tailored to the needs of the person and focused on what is meaningful and important to them. However, access to these type of evidence-based interventions remains relatively limited, and quite often people are primarily offered pharmacological treatment and not allied health support per se. And there's certainly a lot of these interventions are aimed towards doing things for the person. And so when people are not doing the things that are the meaningful occupations that Georgina said, like doing things around the house, like cooking, and there's that support provided, there is evidence to show that can lead to increased disability, further loss of function, depression, and a poorer quality of life. People with dementia are best supported by maximising their opportunity to continue to do things for themselves and continue to do what is important to them. But also, there really needs to be a strong recognition around the importance that family members and care partners play in supporting that person throughout the dementia disease trajectory. Now, it's a bit of a buzz term in research around meaningful activities, but there is a lot of evidence, not just for people who have a dementia diagnosis, but for all people, that being engaged in meaningful activities can reduce loneliness and social isolation, and that can help to reduce the rate of cognitive decline for people with dementia. And engagement in activities beyond what we normally do for people with dementia is a greater indicator of quality of life in the evidence, and they should be tailored to the person's needs, strengths, and abilities. And we also know that doing things in a group, like what Georgina was saying about the amazing Alchemy chorus, which I've had the pleasure to see a couple of times, there's so many different benefits to being in that group environment and participating in something that is enjoyable. And that's certainly shown in the evidence as well. So it's not just about whether someone can actually engage in that particular activity, it's the environment, it's just having that opportunity and that choice to do things that a person with dementia wants to do. And especially when it is linked to their interests. So perhaps things that the person has done in the past, that can have an additive benefit. So definitely people with dementia are able to develop skills even after receiving a diagnosis. And a lot of our work and our interventions that we evaluate incorporate these 5 concepts here. So enabling people to be physically active, being social, building communication skills, their cognitive, exercising their cognitive capacity and perceptual abilities as well. Now, I know typically, and I know Georgina doesn't like this, we don't like to talk about statistics and the impact of dementia, but it is the second highest leading cause of death in Australia and the leading cause of death among women. And here in the ACT, we do have a higher proportion of people living in the community than residential aged care. And so some of the work that we've done is around what are the gaps in dementia services here in the ACT. And we talked to a number of key stakeholders, clinicians, and aged care providers about that in 2022 and 2023. And this is what they told us. There's a lack of dementia-specific services, so not enough day or respite services, and not enough services for people who have some change of behaviours. There is some concern around the quality of existing dementia services. There's not enough funding provided. And also linking into that stigma that Georgina was talking about. that fear around dementia can contribute to people not receiving a timely diagnosis, which then delays their access or their desire to seek support and have that toolkit in place. I'm going to talk about a number of our different projects that we've been doing over the last couple of years. So I'll talk about our post-diagnostic care research. We do done a lot of different research looking into meaningful activities for people with dementia and their care partners. And also just some of the initiatives around small-scale dementia care, where here in the ACT, we have a number of exciting things happening. So we know that once someone is diagnosed, the evidence shows that it is more beneficial to take an holistic approach to lifestyle interventions. And as you can see here on this slide, this is a pretty impressive document in the Lancet. I'm not sure how many of you have heard of that, but it definitely says that interventions that include an holistic approach, so a number of different aspects, physical, cognitive, and functional, are the treatment of choice. So taking a holistic approach to enabling people to live well with dementia. And it's important that they include family carers as well. So here in the ACT, since September 22, we've had the SPICE program, and this was created because there were no dementia-specific services within the public health system. It was a long, winding process to get this off the ground due to COVID-19, but we eventually launched in September 2022. And it really is a multidisciplinary allied health approach. So there's a number of people with different expertise having input into not only how this program was designed, but also the delivery of the program as well. And it's actually spawned off a number of different side projects to make sure that there are services available within Canberra Health Services for people with dementia and their care partners. So this is what the program looks like. It's a pretty intense program. It goes for 12 weeks. It's twice per week in the afternoons, either at the UC Hospital or on the south side at Village Creek in Canberra. And there's also some in-home appointments as well with an occupational therapist and appointments with a dietitian. So trying to sort of capture a lot of the things that Georgina spoke about that are good for us as we age, but also for people with a dementia diagnosis. There's a number of different components to it as well. So probably one of the centerpieces is at the top there called cognitive stimulation therapy. And that's actually the only non-pharmacological intervention that's recommended for people with mild dementia in the United Kingdom. It's a very strong evidence base behind it. And it's really about and giving people with dementia a inclusive, welcoming environment to discuss things that are important to them and to engage in current affairs and to do a range of different activities. It's something that is very popular. Our group members come out of that laughing and with inside jokes with each other. And our clinicians at the UC Hospital and on the south side do a really great job of making that a very fun activity and a way to work on social and communication skills. Georgina's already talked quite a bit about physical activity, and that's a big part of the program. So different activities that help with falls prevention for both the person with dementia and the care partner. There's care education as well from a number of different allied health professionals. And then the different components that they get individually are the COPE program, which is a collaborative problem identification process and then developing strategies to remain engaged that are things that are important to them. Also a bit of an occupational therapy angle potentially around safety around the home. And it's really individualized based on where the couple or the pair is at the moment. Georgina also talked a bit about nutrition. So this is a controversial one for some people, but people do get some advice around their diet and suggestions on how they can improve what they're eating. And that's quite helpful, especially for people who go through our program with other health conditions as well as dementia, such as type 2 diabetes. Probably one of the great things about the SPICE program is that social engagement aspect. All of our groups have to spend a lot of time around each other over those 12 weeks, and we've sort of observed them form different friendships and bonds throughout that time. As you can see, I've got quite a few pictures coming up around people having a good time with each other. They also get to spend a lot of time with the different clinicians who are, very great at working with this population and making people feel very welcome and accepted. I won't bore you too much with our research side of things, but we are seeing quite a number of improvements in both people with dementia and the care partners so far. And a lot of those are maintained after the 12 weeks after the program. And this is just on average, but these results here on the table are statistically significant, as we say in the research world, and our program satisfaction ratings are quite high as well. Some of the keys to success to this program is that social connection aspect. And that's really been seen as a key driver of the program. Quite a number of people who come into our program are socially isolated. So therefore, being able to form a bit of a peer support network and have other people to speak to who are going through similar things is, our participants say, that is extremely beneficial. As I mentioned before, the environment that the clinicians foster is a very welcoming environment, a very positive environment. The care partners say that they're supported with strategies to help and skills to help reframe dementia. And this last one around re-enablement can be fun. I'd used the exercise as an example. Quite a few people come into our group not doing any exercise or physical activity, but the way that it's designed as a dementia specific circuit-based exercise group with some, good music playing in the background and some fun activities means that some people actually do start to warm up to exercise and want to continue it after the program is over. To show a quick video from one of our news clips last year about the experience of two people who went through the program.
Dementia patients and their carers working out new ways to manage their condition. A pilot program helping to keep them at home by combining physical activities with cognitive therapy.
We get to a stage where we think, this is good. And there's nothing else like it for us at this time of our lives.
It helped my dementia as well, so I'm actually remembering a bit more than I was before, so things really well.
The 12-week program creating long-lasting bonds between the participants.
We go there and we'll all the time do different things and we're doing, and so we're actually going on a train journey shortly, and it's really improved my life anyway, and made it not so as lonely as it was.
Nearly 500,000 Australians are currently living with dementia. An estimated 2/3.
So I'll just stop there before my head comes onto the screen. So I guess something that's been just really great to see is just how our groups stay connected after the program and sort of building that peer support network. I think most groups have got their own WhatsApp group. Many of them see each other for lunches and dinners and social gatherings. A lot of them already were going to Dementia Australia memory cafes, but those who weren't, they bring them along. And one of our recent groups is actually, as soon as Spice finished, they started their own exercise group, which was great to see. So the program is funded through the end of 2024. We hope that will continue into the future. We really want it to be sustainable, and we are working to expand this for people who cannot engage in Spice as well, and hopefully we'll be able to test it in different parts of Australia. So let's talk a bit about some of our other work that we've done around meaningful activities. Now, some of you may have heard of the National Gallery of Australia's Art and Dementia program, which has been running for a very long time. And this is actually my PhD research, where we had people with dementia go to the art gallery and participate in arts-based discussion. Similar to in Spice and in cognitive stimulation therapy, it's done in a very safe and inclusive environment where people are not, there's no fear of judgment around what they say. And we did have some interesting results in that. We actually looked at their changes in their saliva and their stress levels and did find a small but meaningful change in those levels, as well as their quality of life. Now, how many of you here have seen the TV show on the ABC, Old People's Home for 4-year-olds or Old People's Home for teenagers? Yep, so it's very popular, won a few awards. So we've done quite a bit of work with one of the geriatricians, who's actually on that show, around intergenerational programs. We did a national survey, which had 572 aged care homes respond. And over here in the figure, you can see some of the benefits that they said from older people engaging with younger people, not only just 4-year-olds, but all the way up until university age. There was a wide scope of different programs that were running. And you can see the top one here, mental health and well-being. So being able to engage in different activities with younger people was seen to be very beneficial, as well as enabling the older people to pass on their wisdom and knowledge to the younger people as well. And to that end, we did a small pilot study as well with Kangara Waters, which is just across the road from the hospital where we're at. And for this particular one, which is different to what is in the TV show, we only included people with dementia, an average age of 91 years. And they were engaging with 4-year-olds, and it was just an amazing experience to be part of that and just see how over the weeks they formed relationships and got to know the children's names. And as in this quote here, actually, physically touching each other and becoming quite close to one another, and just really showed the power of what these type of programs can do. And they've definitely become more popular in recent years, but we think that there should be a lot more of them. And we hope that there will be, and we hope to do some follow-up work on this. Now, I'm not sure how many of you here have used virtual reality before, but we've also done some work around that, both with putting on a headset to be transported to another place. For example, there's ones now that you can go visit Paris within the virtual headset. We also retested it as a physical rehabilitation intervention in residential care, and it was actually quite well accepted by the residents there. We also did a lower tech version where we filmed on a GoPro one of our colleagues, Stephen, riding around Canberra. He would go around the lake. He went down Mount Stromlo, a couple of other places around the War Memorial and that. And we presented that on the screen so and enable people living in residential care who don't actually go outside to be able to cycle along using pedal exercises to those experiencing. And they really enjoyed that. They would break into conversation around their experiences as a child riding a bike. And I think that was a really powerful experience. And there's a lot of that type of thing happening in residential care at the moment. We did take that one step further, and we had high school students, again, factoring into this intergenerational piece. High school students creating the videos this time down on the coast at Brawley. They created different videos walking around Bateman's Bay, walking on the beach with their dog. And I think you can see closely enough, there was a picture of a video of a seal in the ocean, and then enabling the residents to view those together with the students and have conversations and cycle along. That was found to be a good experience as well. We're just about to start work on a program where we have our students at UC go into residential care, living on residential care, living in a residential care home, and providing volunteer time in exchange for their board. So that's something we're excited about starting soon as well. So lastly, I'm just going to talk a little bit about some of our work in small scale dementia care. So we've got quite a few innovators here in the ACT and some exciting things happening. So difference between a regular or traditional residential aged care home and small scale care is the number of people living in the home. So traditionally you might see the larger buildings with 20, 30, 100 people. But there's really a push towards enabling people with a dementia diagnosis who receive care to live in an actual home or a cluster of homes, sometimes referred to as a village. And that has shown some benefits in the evidence. And we have a few examples here in the ACT, such as Canberra House. So it's just a regular home in the suburb for people with dementia, and it has staff there at all times. And that was found to be a very positive experience for all people involved. So both the residents and the staff, as well as the families. And something this organisation does really well is to get things out there on social media and show that people with dementia are living a normal life, going out into the community and doing things that they really enjoy. And that type of model really has a lot of potential around enabling those sort of things to happen. We're also working on having a cluster of these homes in South Jerrabomberra with one of our aged care partners, Hanum Care. So what we did is we talked to a number of different experts around how this could potentially work. where the homes are there in a cluster, but there are no fences around, so people can live as normal of a life as possible in residential care. And a lot of the things that we found out were that the community really needs to embrace living with a cluster of people with dementia in their community, and really factors into some of the stigma that Georgina was talking about, and removing those barriers. But also the people should have that opportunity to engage in meaningful activities that are important to them. But also there needs to be a change in the philosophy of the organisation to empower their staff to be able to provide these sort of experiences for their residents. So that one's just across the border, but the ACT government is also motivated to have a village for people with dementia in Curtin at the North Curtin Primary School site. And there's been quite a lot of stakeholder engagement around that so far. So stay tuned for some more announcements around that as they put it out to tender quite soon. And lastly, we have a number of other different projects going on in our research centre. So storytelling is a project around giving people with dementia the opportunity to tell their life story and have that on a digital record to be able to share with their family and relatives, but also it can be quite helpful if they do need to use healthcare to be able to show that to someone so that they can really get to know the person before they start to treat them or work with them. We do a lot of work around improving allied health in residential aged care. Georgina mentioned my work in nutrition as well, and we're really starting to look at that from the perspective of carers of people with dementia. And we're also working with the ACT Health around a framework for behaviours or symptoms of dementia and how their services can be improved. So just to bring it all together, we've come to realise that socialisation is a key outcome of our work. We know how important it is for people to be connected with others, to have a peer support network, to have friends, to be able to stay and remain engaged in the community. We also know that the health professionals working with them should provide person-centred or relationship-centred care to enable them to maintain their physical, cognitive and psychosocial health. So in regards to the SPICE program, I'd just like to acknowledge the Canberra Health Services team that have put a lot of time and effort into this program to get it started, and hopefully it will continue. We do have quite a long waiting list for that program at the moment, so we do hope the funding doesn't stop and that people can continue to participate in it. And if you'd like to talk to me afterwards about that and what you might be able to do to help us continue that program, that would be great. And I'd just like to acknowledge everyone in our team, especially all of the participants in our research who give their time to take part in our interventions, but also to answer all of our questions. And we do have quite a large team and a large number of funders, and for that, all of our work wouldn't be possible. Thank you.
Thank you so much. So now we are going to have Nicole from Dementia Support Australia who will speak to us. I'll just the presentation.
And it's that it'll do for you, isn't it? That's it, yes. I just go like that. Yeah, or I can just go, yeah. Thank you. Thank you very much. Thank you to COTA for inviting myself and my colleague Anne, who's come from Sydney today, who's also another dementia support consultant, and Georgina and Nathan. Spectacular. So exciting to see evidence-based research in the area of how we can care for people living with dementia. So fantastic. So Dementia Support Australia. Allow me just to put the next slide on. So prevalence, impact, challenge, intervention. Prevalence. So experienced behaviours and psychological symptoms of dementia are experienced by up to 90% of people living with dementia. There can be different levels of behaviours, and I'll talk about that a little later, but so 90%. So what is the change in behaviour? So what DSA does is we're a support service that comes in and we assess and we aim to understand why the person living with dementia, why their behaviours are changing, and how we can respond to them and how the carers can respond to them. Excuse me, whether you're someone, the person's living at home in the community or whether they're living in a care facility. The changes of behaviour, so behaviours and psychological symptoms of dementia, can be due to the changes in the brain, as Georgina and Nathan discussed, the environment, too noisy, too loud, or as also discussed, environments that are not for people who can't remember where a door is or etc. That cognitive impairment someone can't navigate a space. So environment's really important, and health. If you're clinically unwell, you're also going to be having some behaviours and some distress around not feeling well. And another thing that impacts people's medication. Are they being over-medicated, under-medicated, too many medications of different varieties? So all of these changes in behaviours can become disruptive, distressing for the person who's living with dementia and distressing for those people who care for them. When we talk about what the common changes are, what we often are referring to, there's some fundamentals. People might be becoming agitated, they might be becoming aggressive, they're anxious, they become apathetic, disinhibition, they may have visual or oral hallucinations, personal care, no longer interested in their own personal care, as in terms of hygiene care, etc. Sleep changes, as the team discussed earlier. Exit seeking, wanting to get home, wanting to leave where they currently are. And another common change for people is wanting to pace, wanting to walk, being on the move. So the DSA approach, what we're looking at is tailored and personal advice. So if a referral is made to our organisation, a consultant will assess the needs of the person living with dementia. We have a 24/7 phone service, which I will remind you about later, but anyone can ring our phone service. We've got some gorgeous people living in Scotland who answer the phone overnight, so you get a bonus of listening to a delightful accent. So 24/7, we're there. We have a really large intake team. So any question that anyone has, day or night, about behaviours, we can answer that question. And if it's not for us, we'll direct you to who could help you. Clinical expertise. Dementia Support Australia is really fortunate. We have professors, associate professors, who give us our foundation of evidence-based approaches. So we're totally covered in the terms of clinical support. And as a dementia consultant, as I am, if I have a question about, someone's clinical background, needs, etc., we can just immediately access professors, associate professors, specialist geriatricians, psychogeriatricians, etc., all around Australia, and they'll support the client, as do the consultants. I guess the thing that's interesting is that we're a national organisation. I'm here from Canberra, so I know the care homes, I know lots of the organisations, so we can have that local approach, but we are also national, and in fact international with those lovely lasses with the Scottish brogue. We also have an ability to get out in 48 hours. So our service delivery, we have a number of different service levels. One of them is called SBRT, which is Severe Behaviour Response Team. And myself and all the other consultants, we will be on site. This is for care homes or not, unfortunately, for community, but we'll be on site within 48 hours. So that wherever you are, wherever the care home is, we've got people jump on an aeroplane, drive 6 hours, whatever's required. We will go anywhere in Australia for our SBRT clients. So that's an extraordinary service. And of course, industry partnerships, lovely COTA, Dementia Australia, Carers Gateway, etc. Okay, next slide. A model of care. So we're looking at a biopsychosocial approach, as again Georgina and Nathan discussed. You know, where we're all, none of us are here supporting medicating people for behaviours. So we rely upon a detailed psychosocial history. So we want to know everything we can about the person. So when, as a DSA consultant, perhaps I'm going to a care home, or perhaps I'm coming to your home to see how we can assist someone living with dementia, we want to know who this person is. What's their work history? What are their interests? What are their likes? Importantly, what are their dislikes? What gives them joy? What do they really dislike? What were the triggers? Did they have a happy childhood? What's their favourite colour? You know, what's their favourite pet? And we gather that information because it supports us to make an assessment, but also it's really good information for everyone who cares for that person, who interacts with them, to have access to. If we know who the person is, we can care for them. You know, at the very minimum, we've got a topic of conversation. If I know that, you know, someone's favourite animal is a dog called Blue, then any care worker who's coming to your home to help support with personal care, or someone sitting in a dining room in an aged care facility looking a bit down and isolated, anyone can check and say, oh, that person really loves a dog called Blue, and we can chat. Hi, you know, how's your dog? Oh, I've had a dog like that too. Aren't they beautiful? And so it's important to know who a person is. As you can see on the slide, we're identifying causes of behaviours that contribute to the referrals to our organisation. So what are the reasons? What causes the agitation? What causes the exit seeking? What causes the isolation? What causes the disinhibition that I mentioned earlier? Well, pain is one of them. We know that 80% of our referred clients, 80% have unmanaged pain. There's a very fascinating idea out there that people with dementia apparently don't experience pain. Very odd. So that's something that's really important to DSA. Whenever any of our consultants are on site, pain is something that we're looking for. We're educating family, carers and staff how to identify pain and how best to address it. Loneliness, which is something that, again, Georgina and Nathan, you know, eloquently discussed. And as we all know, you can be lonely in a crowd. So that's something that we also particularly look at as dementia consultants, particularly obviously in care homes. You know, there can be a crowd of people, but people are still quite isolated in that space. So social engagement, emotional engagement, rapport with staff, all of the things that, again, the team from UC discussed. Delirium is something that we see a lot with our referrals. So that's when someone's unwell. So someone living with dementia, their cognition is impacted when they're physically unwell. And that is another large component of our clients that we see. Mood disorders, anxiety, depression, over understimulation, again, talking about an environment, but also very much about lack of engagement, you know, the idea of people, I mean, you all have the horror eye image, don't you, of people sitting in princess chairs up in front of the television, which is heartbreaking and doesn't happen as much as it used to, which is gratifying. So all of our reports, all of our recommendations, all of our strategies always have a component of what's that person, what would give them meaningful engagement, what would reference to who they were and the activities they used to undertake. And finally, care approach. So how does staff or family interact with a person living with dementia? How do we communicate? What's our tone of voice like? What do we do when we're getting a bit tired and cranky, and, you know, how many times can that question be asked? So how can we support carers, family and staff to monitor and understand that their communication is so fundamental in the well-being of someone living with dementia. This next slide just shows where we go. Here you can see there's an office here in the ACT. We currently have 3 dementia consultants in the ACT. We're looking for a 4th if anyone knows anyone. I think I get $100 if they get employed. More, excellent. But the New South Wales team come here to support us. We have quite a few referrals here, and that's because we're a highly educated and informed and health literate population, and hence I think Nathan mentioned the number of referrals we have, and that's because the care homes here and the families here understand that we're a service that can support them. So there's this fabulous thing called the Brodati Triangle. Now, the Brodati Triangle, I don't want to bore you all. However, it's interesting because this is what we've based, DSA has based our levels of service delivery upon. There are 7 tiers of this exciting triangle. Okay, so tier 1, someone without dementia. Tier 2, they're at home, they're living with dementia, but at this stage they have no behaviours of concern. And at that level, we have something that we deliver called staying at home. Staying at home is a carer wellbeing and respite program. So it's helping people with dementia to stay home longer. And also upskilling carers. Because I think for carers, you know, as the Spice program that you guys are running at UC, just that beautiful opportunity to get information, isn't it? And so this respite program is you go and live in a facility for a couple of nights, usually 2 or 3. The family carer and the person living with dementia. We have OTs, etc., a whole team that come and upskill and give respite. So in the ACT, Carers ACT deliver that program here. DSA also does, but just to let you know, Carers ACT have a program themselves here. After our session, we've got some information about all of our services and the staying at home in particular, which you might find interesting. So the next level is tier 3, mild behaviours, and tier 4, moderate. And the service that we deliver here is called DBMAS, Dementia Behavioural Management Advisory Service. This is short-term case management. We'll come out on site to a family's home, assess someone, then give recommendations through a report or a letter with tailored strategies and advice. Those cases, it is short-term. We're imagining that maybe 8 weeks we might be involved. And so we would give the family or the care home our report, discuss other resources and call up each week, how are you going? Has it worked? Has it not worked? What else could we do? What are some new strategies? This next level, this is the SBRT, the team that get there in 48 hours. And you can see that they're dealing with people with severe behaviours. So that's the frequency of the behaviours, the outcome of the behaviours, and the impact of the behaviours. So we attend within 48 hours. We offer a tailored advice and strategies to meet that individual's needs. Our clinical members, our clinicians are involved in that care. And those cases can be open for years. Now, years is an exaggeration, but for example, I have one open at the moment that's been open for 45 weeks. So we stay involved, we call up This is not for community. This is for residential care. We will call the care homes once a week. How's it going? What can we do? Did it work? Great. Did it not work? Okay. Let's think of something else. Can we throw some more resources at you? Can we support someone to come into the care home and do some additional activities with the person, example? And our last, the top of the triangle. So tier 6 is very severe behaviours, and these basically are people who cannot be cared for in a standard residential care home. And tier 7 people, that's quite rare. So Dementia Support Australia's role in the specialist dementia care program is as an organisation where the organisation will go in and we're assessing eligibility for that level of care. Around Australia now, I think the intention was to have 30 XTCP units eventually. In the ACT, we have one, which has 2 units. It's at Uniting Ebray. And so what happens if someone is determined eligible by a DSA consultant, then there's a process where the family, the care home can see whether there's a space available, for example, in the ACT at Ebray. If there is, then that person living with dementia can go into Ebray, for example, and usually for about 12 months, be cared for in a totally beautiful little memory support unit with highly trained and dedicated staff. And then hopefully after 12 months, their behaviours will have reduced to such an extent that they can then return to a standard aged care facility. So, but that's at the top of that pyramid. That's where things are, you know, someone is very, very distressed. And this slide just shows you everything that I've just described. Client pathway, how do you get to DSA? How do you find us? So a referral, we have a website, Dementia Support Australia. It's a great website, got lots of resources, videos, information, but you can make a referral there. A loved one, a family member, a community provider, a neighbour, a person living with dementia, anyone can contact us and have a discussion, and then we will discuss where that person's level of need is and do you fit into any of those items on our Brodadi triangle. So the referral's online, or you can call our helpline and have a chat to a gorgeous consultant, and they'll talk you through the process. And so that's the triage process. So you're going to be a DMAS case, SBRT, needs-based assessment. Then we assess and plan as part of how we're going to support you. Then we implement the care with reports. We have dementia support workers who are now called dementia support coaches, who go either into the family home or to a care home and implement the consultant's recommendations. Brokerage, we can buy things to help support the implementation of our recommendations, etc. Monitoring, we continue to assess and evaluate, and closure. Have we improved the behaviours for the referral? Did pharmacological intervention, was it reduced? Caregiver distress, has that been reduced? Have we delayed the transition from home into an aged care facility? And importantly, have we improved the client's quality of life? Here's another map that shows off where we go. You'll notice someone went to Lord Howe Island. So yes, we're everywhere. We're a bit like the Mounties. So the next slide is outcomes. So just like the SPICE program that Georgina and Nathan are working on, it's really important to know that what we do does have positive outcomes, and we know it does. So you can see DBMAS, reduction in carers distress, 64%, reduction in the severity of the client's behaviours, 59%, and the number of client behaviours, 42. I mean, it's, you know, we know that psychosocial approaches to dementia care and to care for people in distress works, and it is the first line before any talk of antipsychotic medication. My next slide's about the support services and organisations that we work with. So obviously Dementia Australia, Dementia Training Australia. Has anyone ever heard of Dementia Training Australia? There we go. Thank you, Georgina. So that's an organisation that we certainly, when we're working with care homes, we put in recommendations and referrals directly, because they're a team that can help build that capacity in the staff of care homes across Australia. I'm sure many of you are aware of Carers Australia and, of course, Care Gateway. And COTA. Jerry's story. We could have probably had a story that wasn't for someone who is an aged care facility, but this is just an example of how DSA work. So here's Jerry. You can see 72, factory worker, committed union member, married, currently living in a residential aged care home. He's got pain from a lifetime of manual labour. He loves to sweep, and he's still doing that. So that's an engagement, an activity the team are giving him at the care home. A lifelong suspicion of authority. He has frontotemporal dementia. So when DSA met Jerry, he was referred to us because of, quote, daily threats and physical aggression to staff and visitors. A fairly common referral, actually, that sort of language that we might get from a care home. So the DSA consultant would go on site. Now, we don't go on site for several days, but we undertake an assessment for several days. So we'd go on site probably minimum 4 or 5 hours at a care home. We're reading all the documentation. Once we get back to the office, we're making phone calls, speaking to family, etc., etc. When we're on site, and of course dealing with GP, but when we're on site, we're really spending a lot of time observing. We want to see Jerry, and we predominantly want to hear what the environment, what's his room look like? How do the staff talk to him? Who's he sitting with in the dining room? What's his clothes look like? How's he moving? So our assessment is very observational. So aggressive towards staff, taking notes on clipboards. So you might see in a care home, if any of you have ever visited, not so many clipboards these days, but there's lots of people on tablets, you know, like your little iPad. And so they're always looking at an iPad, and then they look up at the person with dementia, and they look back at their iPad, and they're going like this. So someone like our Jerry, who's already is a suspicious human being, he's interpreting that as management snooping, as he would. Apparently he's targeting male staff and visitors wearing white shirts. Again, he's looking at management, you know. He's a historic unionist. Who are these managers coming in here and looking at me and watching me? And some other relevant issues that were found within the assessment process. Our Jerry has 6 cups of caffeinated coffee a day. He has inadequate pain management, aggravated by apparently a short-handled broom that the staff have given him, and he's got constipation. And constipation is also something that causes people living with dementia, you know, distress, makes them unwell. So how are we going to support Jerry? Staff capacity building around the contributing factors, his heightened response, a review of the analgesia, and his bowel regime. We do a lot of talk about, toileting schedules. Has someone gotten to the toilet? Buying a new broom, something that's actually suitable for Jerry's height. And please switch to decaffeinated coffee. We have so many clients that we see that we're seeing them because of disturbed sleep. They're up all night. And you go, oh, okay, what do they drink? 6 cups of decaffeinated coffee a day. And/or what do you do to help get them to bed? Oh, we give them a coffee. That might happen 3 times across the night, which is so lovely. The staff say, come on, I'll make you a coffee and let's come and have a sit down. But they're giving them caffeinated coffee. So these are the things that, in care homes and in your homes, you kind of, it's good to have an extra set of eyes, isn't it? For someone to come in and just be able to pull everything together. This is a very nice quote from Jerry's daughter. And so what DSA did in that case was not rocket science, was it? Some really kind of fundamental, easy things for people to change. And that's what DSA do. We go out, we assess, we make really practical and concrete recommendations that hopefully can improve someone like Jerry's life and make his daughter less distressed. Also, hadn't shown me that. There it is. Do you need to read it? He became happy and joyful. And so that is the joy for us at working at DSA, how often we have these outcomes. It's quite beautiful. So, Dementia Support Australia, you can call us. This beautiful 24/7 service, 1800 699 799, and we've got that number on some of the materials that you can grab. You can email us, you can visit us on our website, and we also have a live chat as well. So myself and Anne will continue to stand behind our little table down there. We've got resources if any of you would like them, and also very happy to speak to anyone with any questions that you may have. Thank you.
Thank you. Thank you everyone so much for coming, and to our speakers, Georgina, Nathan and Nicole, and Anne for coming along as well. As Jenny mentioned at the start of the session, next month we're talking about heart health. So we have the Heart Foundation coming, so we'll be sending information out about that. We have some afternoon tea that we're slowly putting out, and one of the best things about these sessions is bringing these subject matter experts into one place. So please take advantage of it, grab them before they go and ask all of your questions. But thank you all for coming.